All right, let's talk about an organism that I'm sure many of you are seeing more and more, Kocuria rosea. For a long, long time, this was the bug we'd just write off as a contaminant. But the game has changed, and frankly, so should our thinking.
And that really is the million-dollar question every time, isn't it? You get a plate, you see this characteristic pinkish colony, it's a gram-positive coccus. So, is it just some skin flora that dropped onto the plate, or is this the culprit behind your patient's fever? That's exactly the challenge we're diving into today. Now, just a quick heads up on our process here. We put this review together using Gemini Deep Search to really dig into the current literature. If you want to see all the papers and sources we're referencing, you can find a complete list in the notebook document that goes along with this explainer. So here's our roadmap. First, we'll look at how Kocuria rosea went from being just a bug to a real pathogen. Then we'll hit the lab to see how we can unmask it. After that, we'll look at the clinical side. Who gets sick? We'll wrestle with the treatment dilemma, and we'll wrap up with some key points on infection prevention and control. Okay, Section 1, a pathogen in disguise. You know, for decades, if you saw Kocuria rosea, you just thought environmental noise. It was that bug you find in soil, water, and yeah, all over our skin. It was just part of the background. But the evidence now is, well, it's undeniable. This gram-positive coccus, which some of you might remember as Micrococcus roseus, is a legitimate opportunistic pathogen. And the pattern is incredibly specific. It loves to show up in immunocompromised patients who have some kind of indwelling medical device. So the takeaway here is that context is absolutely everything. All right, let's head over to the lab because this is where the story really gets interesting. For a long time, we've had a massive diagnostic blind spot. A big reason its true impact has been underestimated is simply because it's so good at mimicking other, more common organisms. So, you start with the gram stain. You see a gram-positive coccus. But the real morphological clue, the thing you're looking for, is that classic arrangement in tetrads. Now, here's a little pitfall to keep in mind. Older cells can sometimes look gram-variable, and that can really throw you for a loop. On the plate, it's pretty straightforward. Non-hemolytic with that famous pink to red color. Biochemically, it's catalase positive, coagulase negative. Pretty standard stuff. But, and this is the critical part, highlighted right here, the oxidase result is variable. This one inconsistent test is the source of so much confusion in the lab. And this slide just lays it out perfectly. Look at that comparison with coagulase-negative staph. On your basic tests, they look almost identical. If you happen to get an oxidase-negative result with your Kocuria rosea, it's almost impossible to tell it apart from cons phenotypically. And what do we do with cons? We often dismiss them as contaminants. This is exactly how a real pathogen gets missed. So what's the fix? How do we get around this? Well, we escalate. Honestly, the widespread use of MALDI-TOF mass spec has been a total game changer here. It gives us a rapid, accurate ID. And of course, for the absolute gold standard confirmation, we've got 16S rRNA gene sequencing. These tools are the reason we're discovering more Kocuria infections. It's not a new bug, we're just finally getting good at seeing it. Okay, so we've nailed the identification in the lab. Let's get back to the bedside. Who is actually getting sick from this organism, and what do these infections really look like? The number one thing we see, by far, is catheter-related bloodstream infections, CRBSI, especially in patients with central lines. It's the classic presentation. We also see it pretty frequently causing peritonitis in patients on peritoneal dialysis, and while it's much rarer, it can cause some really nasty infections like endocarditis, UTIs, and even meningitis or brain abscesses. This really brings us to the core concept here, the device-host-pathogen triad. Look, Kocuria rosea isn't some super aggressive pathogen on its own. It needs the perfect storm to cause trouble. You need a compromised host, and you need an indwelling device that gives it a highway past the skin barrier. When you see that triad in a patient, and you get a positive culture, that's a massive red flag. And now for what might be the hardest part of the whole conversation, treatment. We can identify it, we know who's at risk, but actually treating it is a huge challenge. We are truly navigating what you could call an interpretive crisis. This quote just nails the problem. There are no, and I mean zero, official species-specific clinical breakpoints from EUCAST or CLSI for Kocuria rosea. So what do? We often have to use breakpoints for Staphylococcus as a stand-in, but let's be honest, that's just an educated guess. This is that interpretive crisis we're all facing. So what's the workaround? We have to extrapolate. We look at guidelines for the syndrome, not the bug itself. So based on guidelines like the Dutch SWAB or the International IDSA, we make some reasonable choices. For a complicated UTI, maybe ceftriaxone. For CRBSI or endocarditis, vancomycin is probably your safer empirical choice. But look at the key pearl for CRBSI, because this is the most important part. Catheter removal is critical. It's the #1 intervention, bar none. And what about kids? Well, if you think the adult data is thin, the pediatric data is basically just a handful of case reports. The principles are the same, source control is everything, and you have to dose by weight. But honestly, you absolutely have to get a pediatric infectious disease specialist involved. No question. You know, that point about source control is the perfect lead-in to our final section, infection, prevention, and control. With an organism like this, the best treatment is always prevention, and the name of the game is source control. The very first step for IPC isn't about isolation or precautions. It's a clinical judgment call. Is this a true infection or is it contamination? And that decision requires a tight conversation between the lab and the clinical team. You see multiple positive bottles. The patient fits that triad we talked about. That's when you lean towards it being a true pathogen. The answer to this one question drives everything else. And since we know most of these are device-related, prevention really comes down to being fanatics about the CRBSI prevention bundle. This isn't rocket science, it's the fundamentals. Obsessive hand hygiene, maximal barriers, proper skin prep with chlorhexidine, and, maybe most importantly, asking every single day, does this patient still need this line? So, do you need to put these patients in isolation? The short answer is generally no. The transmission route here is auto-inoculation. It's the patient's own skin flora getting onto their device. It's not spreading from patient to patient. Because of that, standard precautions are usually all you need. Contact precautions are not typically required.
So let's bring it all home. Kocuria rosea is an unmasked pathogen. We just can't afford to dismiss it anymore. And managing it really boils down to 3 key things: getting an accurate ID in the lab, working with the clinical team to separate the real signal from the noise, and being aggressive about source control. That's the modern way to handle this bug.
But look, the learning doesn't stop here. That line between a contaminant and a true pathogen can be really blurry. So I want to turn this over to you. In your lab or in your hospital, what are your criteria for working up Kocuria rosea? What are your experiences? Please share them in the comments below. Let's build up our collective knowledge on this.
Thank you so much for joining this explainer. If you found it helpful, make sure to subscribe for more deep dives into the organisms that matter in our labs. And please, do leave your feedback below. We really do read all of it. We'll see you next time.